It's a pleasure to be invited by the Centre's team to present and chair the afternoon session today. I'm relatively new to Singapore, but I've worked in the ethics of home and community care for some years, and I'm very interested in this terrain and how we think about duties, obligations, and the ethical character of this kind of work. We are moving gear in terms of what we're focusing on today. So this afternoon we're looking at care relationships and potentially some problems that can arise within those relationships, the ways that vulnerabilities manifest in caregiving and care recipients, and also how we respond to those, particularly in cases around abuse, neglect, and other adult protection type scenarios. One of the topics that we as a team think is distinct and important in this setting. Now, I am going to start by building very much on what Jacqueline Chin and indeed Wai Chong mentioned this morning, thinking about the foundations, the distinctive ethical duties that might apply in the home and community context. But unlike Jacqueline's approach, where she started with the idea of the aging person and what we owe to a person who is in old age, I'm going to focus on the home care context itself. And I want to argue that this context, the particular place of care being in the home, gives rise to a distinctive ethics, a distinctive set of ethical problems, and a distinctive set of ethical considerations. So we're going to get, I think, myself and Jacqueline to the same point, but in the words of Derek Parfit, the philosopher, we're going to scale the mountain from different directions. We're going to articulate some overarching considerations and duties, but we're going to go about it in slightly different ways. So my plan for this afternoon and my first talk before we launch into our further panel discussions is to think about first what is so distinctive about the home context and the practice of care within it. I'm then going to move on to thinking about how that connects us to thinking about the ethical foundations of care work in that context. I'm going to put forward three very similar parallel considerations that Jacqueline articulated. The idea of configuring benefit as the maintenance of capabilities, the idea of moving from a broad respect for autonomy to supporting agency, and the ethical importance of maintaining trust in relationship. And then I'll think about how we might move to the adult safeguarding context to start thinking about the application of some of those considerations in particular. But first I want to lay out three foundational things, or foundational features of the care at home context, and see what you think. In my view, these realities of the home environment and our care in it give us space and reflection for new ways of thinking about the ethics. So the home is where lives are forged. Hospitals, in contrast, are where someone goes for treatment. And I will draw this distinction between the home and the hospital repeatedly. I don't want to overemphasize that distinction. I think there are grey areas in between, but by and large, I think that's a distinctive feature of care in this setting. So when we live in our homes, we are in the business of living. They're the place where our plans take shape and are realized, where our relationships are carved out, where we forge our identities. And when we enter into a person's home to provide healthcare or any other kind of social care or social support, we enter the most intimate and private space of a person's life, a place under the control of the recipients of care and their families providing care. And in an important sense, and unlike the hospital, the professional entering that space is out of place. It is not their space, it's not their place. It is the place of the care recipient and caregiver in the family. Secondly, care provided at home, I think, must be responsive to distinctive manifestations of human dependency. When we think about the people who receive care at home, by and large, they have long-term impairments, chronic illnesses, or perhaps live with enduring disabilities. Some age-related, some potentially not. And care interventions and our care plans for people are situated, I think, along pathways or journeys. With no obvious start, we just find ourselves needing care and receiving care, and providing care indeed, and no obvious end other than death, perhaps. And in my view, the outcome of this journey of care provision in the home is not one of independence. We don't end up recovering and returning to the norm. We are in continual need of assistance. And that, I think, again, contrasts in important ways with the hospital environment. Finally, care at home, I think, is configured in day-to-day care activities through a complex and very unique network of people, interventions, supports, and relationships. I think it's right to talk about the disorganisation of home care rather than its overarching model or organisational structure or system. We know that the family takes primary roles and responsibilities in caregiving, but of course families have divergent responsibilities. They are certainly not unique, and they're certainly not consistent in how they behave or how they construct their expectations within their own unit. We also know that there are multiple service providers providing multiple interventions. Healthcare providers, primary care providers, NGOs providing social supports, often in the charitable sector, people coming together, providing lots and lots of different things for people in need. We also know that there's a presence of multiple types of people. Some professional, some what we might call paraprofessional, that is to include people like befrienders, volunteers, perhaps foreign domestic workers who may have some training and some inculcation into care work, but by and large aren't sat within institutional frameworks that come with professional codes of conduct, for example. And of course, non-professionals, by and large the family. So I think we can see home care as a web that is constantly evolving as different parties come in and out, and changes in terms of the interventions we offer, and a certain degree of fragility. Namely, if one of that piece of that web starts to disappear or is changed, the whole web could collapse potentially. This is very distinctive and importantly unique, I think, about the home environment. And we also have, of course, this idea in Singapore particularly, an underpinning philosophy of the many helping hands approach, accentuating the idea that our neighbours, our community members, our friends and our family share in the enactment of this web of care responsibilities. So, my sense already is that these relatively distinctive characteristics of care at home mean we have to be very careful about transposing well-established principles from clinical ethics straight into the home care environment. And our first concern, as Jacqueline has already started us on the journey towards, is on understanding and perhaps further developing or refining the core ethical duties that professionals have when they enter into this care context. Configuring benefits as the maintenance of capabilities. Now, typically when we think about duties and beneficence in clinical ethics, we tend to configure these in clinical or medical terms as a set of health-related outcomes that we're trying to bring about, perhaps tied to a particular kind of objective account of well-being. But in contrast, I would suggest, care at home is the business of supportive life management. And the purpose and the benefits we put forward as professionals in that context is the realization of a life managed through support well. People, as I said, have impairments, illnesses or disabilities, and that can prevent them from engaging in a wide range of activities commonly understood as being part of a life lived well. And this idea of the capability of being and doing the things we have reason to value draws heavily on the deeper understandings of Nancy Jecker's work and others that Jacqueline mentioned this morning. Now, that's not to say, of course, that healthcare interventions to benefit patients in the community or at home have no place in this approach. It's just to acknowledge that they're situated, and the bringing about of good health outcome is situated within healthcare interventions that are part of this broader overarching goal, in my view. They're subsumed within that goal, namely, to enable that person to be and do the things they have reason to value. That is the telos or the purpose, the benefit of that care at home setting. Now, the second consideration that Jacqueline articulated and I want to develop further is this idea of respecting autonomy to supporting agency, a shift in orientation rather than an overarching replacement from autonomy to agency. It's more of a change in emphasis, I think. Again, we know respect for autonomy, a core principle in clinical ethics, some people saying the most important of them all. And typically, in the clinical context, we understand this respect principle to focus predominantly, at least, on the act of decision-making itself, how we respect self-determination in the act of making a single decision, often through explicit consenting processes, for example. But in the home care context, again, I think this focus needs recalibration. Time-slicing decisions does not fit well with an approach to care that is both forward-looking and backward-regarding. We have to look to where the person has gone to get to where they are today, and we have to look forward to the places we might want them to get to. That is a little bit different, I think, to how we might think about and situate respect and decisions in the context of the hospital setting. Care practices are ongoing and continuous, characterised by a chain of decisions. We might want to think, therefore, about gaining broad permissions for care journeys, drawing on the concept of something like process consent, which has gained quite a lot of support in the research ethics context for thinking about how we enable the participation of people with dementia in medical research, for example. And equally, and just as importantly, there are concerns about the extent to which care recipients can act on the choices that they make, rather than simply on their ability to make those choices. We are in the business of life management, shaping people's lives so that they can enable themselves to fulfill certain capabilities. And so it is not merely the choice that matters in respect terms, it is the freedoms that enable the enactment of that choice, the mechanisms by which we can help people to live as agents, carving out lives of their own. So, shifting the focus from individual acts of decision-making and consent, I think gets us towards respecting, enacting and realising a self-determined life plan in the home more directly. That's a reorientation to thinking about what that respect principle might look like and how it might fulfil agency support type interpretations. And so the obligation might be to ensure the freedoms and abilities are in place for that person to act on choices rather than simply to be determined about whether they can make that choice. Importantly, for professional caregivers in the home, that might mean targeting the non-professional support network in place rather than the care recipient themselves, i.e. the key to unlocking the recipient's agential control over their life might be helping a family member or a foreign domestic worker, for example, who's struggling to cope or who doesn't have the skills needed to enable the persons to be supported in the right kinds of ways, to gain that support, to build that resource up. And finally, the third reorientation in duty is this idea that Jacqueline introduced about maintaining trust in relationship. I think it's really important to place trust front and centre in thinking about the ethical dynamic of care at home. Many people providing care are not bound by duties or obligations in the strong sense of the word. They enter into entrustments between each other, constantly being reconfigured, constantly being negotiated and managed. The exercise of what Jack interpreted as discretionary power within families or broader social relationships. This, I think, gets to something that Yong mentioned about this idea of configuring patient or person-centric approaches in ways that emphasize the relationship in which people are bound. And so within an intimate caregiving relationship that involves families and other caregiving, home-based caregivers, it is trust rather than duty that underpins the role that those people play. In my view, professionals' responsibility here, therefore, is to negotiate and maintain trust as established and managed within that familial context, to work within existing and intimate caregiving relationships rather than to be situated outside or beyond them in that sense. Okay, that's enough. That's a whistle-stop tour of duties. Obviously, playing a bit fast and loose with arguments there. You just have to hold those ideas in your mind, and of course we can discuss them further if you disagree. But what does this mean for day-to-day ethical decision-making or day-to-day ethical practice? How do we discharge these duties as professionals working in the home care context? Now, over the next couple of days, that's going to be interrogated from different angles. Tomorrow we will look at the ways in which dementia care and the family is supporting people with dementia in care work. In the afternoon tomorrow, we'll turn to issues around loneliness and how we might think about duties in relationship to loneliness. But for this afternoon, the particular ethical issue in which we might think about discharging these kinds of reformulated duties is in the adult safeguarding context. The idea about how we think about our obligations as professionals to be involved in the act of safeguarding an adult from abuse, neglect, or self-neglect as it presents in the home environment. And this is relevant and, unfortunately, a reality of caregiving because care breaks down. It is not always ideal in how it is undertaken, carried out, or planned. And it can break down in the face of dependency, unpreparedness, or simply the overarching burdens of the act itself. Caregivers can act nefariously, or they can simply struggle to cope in their roles as caregivers. And the questions then are questions like this. What ought to be done when this happens? How should adult safeguarding or adult protection be operationalized? I personally prefer the term adult safeguarding just because I think adult protection brings with it a normative commitment to protection that I want to challenge later in this presentation. But we can use both of those terms interchangeably. And importantly, what ethical trade-offs arise and how should these be addressed? Now, we're going to get to the ethics of these kinds of questions quickly, but it is important to recognize, as was mentioned by a colleague in the table over there, that there is a very strong, clear, and rigorous legal framework in place in relationship to decisions and negotiations of these kinds. The Vulnerable Adults Act of 2018 is Singapore's approach to providing a statutory framework for addressing adult safeguarding issues. It does a number of things, including providing legal definitions of who a vulnerable adult is and the person who falls within the remit of the legislation, what abuse, neglect, and self-neglect consist in, and it clarifies the responsibilities of adult protection services, typically operating within the Ministry of Social and Family Affairs, I think it's called. And we have a colleague on the panel later from that context who will be able to help us talk through some of the practicalities of these kinds of decisions. The VAA authorises, in addition to those definitional works, interventions to safeguard vulnerable adults, clarifying what interventions are legally justified and the circumstances in which they can be enacted. Now, there are a range of interesting conceptual and ethical issues in this terrain. I've been thinking about it for about 15 years. I really like this stuff. I think it's quite hard and quite complicated. But we do have to go quite slowly, I think, through some of these questions and hopefully have an interesting and engaged conversation about these things together. Because care goes wrong, care can be undermined in various kinds of ways, and people can present with safeguarding needs of very different kinds. One core conceptual issue in this area is how we make sense of abuse in the context, at least, of adult safeguarding. Now, the VAA does not provide a specific definition of abuse. Rather, it lists different types. Not an uncommon legal strategy in this area. It happens in other jurisdictions as well. And it lists physical abuse, emotional and psychological abuse, a particular account that looks very much like what we could call coercive control, and the deprivation of liberty imposed by somebody else on another party. It's also been clarified in the case law since the VAA was introduced that the intent of Parliament was to limit its scope of the legislation to those kinds of abuses and not, importantly, to incorporate financial abuse. Now, in other policy contexts outside of Singapore, the concept of abuse to motivate adult safeguarding law or policy has been defined in broader terms, or perhaps even in more specific terms in other places as well. Perhaps either in terms of the mere causation of harm or as a straightforward breach of a human right. Now, I've taken issue with these approaches, and lots of people have argued in adult safeguarding context that there's a definitional disarray around how we think about abuse and what we're trying to do in response to abuse. And I put forward a claim, I'm not suggesting you buy this, but you may want to think about it, that we could understand abuse in the adult safeguarding context as wrongful behaviours within relationships that cause harm. And I'll give you the reference to that paper later. That's one way of making sense of whether an abuse is occurring or indeed some other kind of harm. or wrong. The second conceptual issue is to tie or to tease apart these concepts of abuse, neglect, and self-neglect. They all fall within the VAA, but they, I think, have important distinctions to draw out conceptually. Now, I take the view, again, challengeable, please do challenge me, that abuse and neglect are close conceptual cousins, and the best way to understand their relationship is like the distinction between an act and an omission. If we omit to care, we might neglect somebody rather than abuse them, but we predominantly are doing the same kind of things wrong in ways that cause harm within relationship. Now, importantly, on my account at least, our intentions when we are liable to abuse or neglect are not part of the conceptual account itself. We might excuse abusive or neglectful actions on the basis that they were not intended, but that they were not intended does not mean that they are not properly described as abuse or neglect. In important contrast, self-neglect is, I think, entirely conceptually distinct because it has no relational component. It is within the person and their own behaviours towards themselves. And I think responding to self-neglect raises separate ethical considerations that we can talk about later if we wish. The difficult thing for the adult safeguarding legislative frameworks, and indeed for adult safeguarding practices in social services, is that they cover much terrain, but the distinctions matter in how they go about their business and how they fulfill these kinds of obligations in light of distinctions of these kinds, I think. And the final conceptual issue is this concept of the vulnerable adult themselves. In Singapore, under the VAA, and indeed in England as well, in law, policy and practice, those adults who are seen to be experiencing or identified as being at risk of abuse or self-neglect, or indeed often, and neglect as well, are frequently referred to as vulnerable adults. Not universally so. In Scotland, for example, they prefer to call these people adults at risk rather than vulnerable adults. But it is a dominant concept to open up the kinds of people who fall within the bounds of the legislation or the policy. Under the VAA, explicitly, the vulnerable adult is an adult over 18 in this legislation who is, by reason of mental or physical infirmity, disability or incapacity, incapable of protecting himself or herself from abuse, neglect, or self-neglect. Now, that very much places vulnerability and the idea of who a vulnerable adult is by reference to intrinsic or inherent features of that person. One has a status by reference to one's infirmity, disability, or incapacity to be a vulnerable adult. And I've argued that's quite problematic, given that we might want to think that vulnerability and the vulnerable adult is solely determined by reference to their situation, the asymmetric power relationships they find themselves within, their personal circumstances, for example. And if we accept that move towards a situational account of vulnerability, we link adult safeguarding in the home and community care context very closely to the way we think about domestic violence, for example, and gender violence within intimate relationships. Okay. That's some conceptual issues to discuss. We also, I think, have to interrogate some particularly practical ethical issues as well. One of the questions that falls out of the law but also arises in practice and needs to be negotiated is how should adult protective services respond to reports coming from different sources of vulnerable adults being abused, neglected, or at risk of abuse or neglect. Now, I think it's pretty clear when we think back to our principles, our refined duties in home care, that the emphasis here lies firmly on considerations like family management, relationship support and counselling, underpinned by this very calibration towards supporting agency and maintaining trust. So I would like to suggest that those who work in the adult protection space are responding proactively, very pragmatically much of the time, and non-judgmentally within the family as the unit of intervention, targeting both the person at risk of abuse and the putative abuser, with the appropriate supports to support, perhaps rebuild trust in that relationship, or to enable the person who is at risk of abuse or being abused to get on with their life, exercise their agency, and realise the good life in that sense. So that's a broad kind of ethical orientation towards the act of adult protective services. There is, however, an interesting ethical hard case that arises in this setting, and that I have been interested in for some time, and I think is particularly interesting because of the powers allowed for within the Vulnerable Adults Act in Singapore. And the question that arises in this context is something like this. Can it be ethically justified to take sometimes very invasive measures, for example, to remove the person from their home, to restrict contact with their family members, and indeed to perform medical interventions to discover the scope of abuse or neglect, when all of these things are met, namely that they are being abused or identified at risk of abuse, and when they have been identified as retaining the mental capacity to refuse help from social services and adult protection teams, and when that person is exercising that refusal of help in a very clear and rational manner. That I take to be the hard case, or one of the hard cases at least, that ethicists interested in these kinds of issues need to think through. Let's take a case scenario to discuss how this presents. This is adapted from a very recent family court case in Singapore, Director General of Social Welfare v. WHC. I have adapted it. It is broadly similar, but there are some permutations that I've adapted just for the purpose of our own analysis today. It's a bit long, but bear with me. I think it's useful to have a case to work through. Madame Lily is a 65-year-old single woman who lives with her mother, Madame Khan, in a 5-room HDB flat. Madame Lily is a retiree who used to be a polytechnic lecturer. Although Madame Lily has 5 other siblings, both she and Madame Khan have limited or no contact with them. Madame Lily's siblings reportedly keep their distance from Madame Khan to prevent her from harassing and hitting them. Madame Lily has no other friends or social supports outside the home. She lives a fairly isolated existence with her mother. In May 2002, so 20 years earlier from now, Madame Lily was diagnosed with schizophrenia. Since 2021, Madame Lily has been admitted to Tan Tock Seng on multiple occasions for insomnia, potentially, we think, the medical opinion is, a sign of psychiatric relapse. Madame Lily demonstrates subtle symptoms of cognitive decline in relation to her chronic mental illness. Moving on. Madame Lily has experienced recurrent physical abuse at the hands of Madame Khan, her mother. Madame Lily herself has reported that Madame Khan slaps her, pulls her hair, and hits her with a walking stick on a frequent basis. This has led to extensive injuries needing repeated medical treatment. Neighbours have also observed Madame Khan screaming at Madame Lily, with Madame Lily cowering in fear. When Madame Lily wants to leave the home, neighbours report that Madame Khan prevents her from doing so. Now, firstly, just to note, this is kind of a reversal of the typical adult safeguarding type scenario, in that it's the older person who looks to be the abuser against the daughter. That's not typical, I should say, in elder abuse type scenarios, but it was the presentation in this court case. And indeed, there have been very, very few court cases in Singapore that have applied the VAA, so it's one of the few real cases to get our teeth into so far. Now, the Director General of Social Welfare is requesting the judge has come to court to issue orders under Section 14 of the VAA to remove Madame Lily from her home for a period of 24 months, as well as imposing limitations on contact between the two women. In the real case, there was a preliminary set of restrictions already put in place. This is a renewal and extension of this, hence why it's 24 months and not perhaps a shorter period of time. We can change the time length if we want. I don't think it makes too much difference here. Whilst Madame Lily is struggling to protect herself, she is assessed as possessing the mental capacity to understand the proposed action plan. That is the adult protection plan. She is strongly resisting any changes in her living circumstances. She says that she is the only one who can make her mother change her ways, and that her own mental health will suffer if she's forced to live in a strange place. She has a good understanding of the legal process and makes it very clear that if the judge finds against her, she'll appeal the orders made. Okay, so that I take to be the case-based realization of this hard ethical scenario. And the question, I guess, here is, are we justified ethically to impose those kinds of orders in a case like this, when a person is being abused, when they have the capacity to say no, and they are saying no very clearly and coherently so? I want to review 5 kinds of arguments that might help us to identify reasons through which we might think we can ignore or overturn the refusal of permission in these cases of this kind. The first one is a starting point. I don't think it gets us very far, but it's a starting point. It's a capacity-based justification. It's commonly argued in some of the elder abuse literature, for example, that the impact of abusive behaviours, or indeed even being at risk of abuse, are so impactful in the ways they cause distress or fear to a person with vulnerabilities, mental disorders, cognitive decline, for example, that they can overwhelm decisional capacity. The person is rendered incapacitated by the impact of the fear of abuse or its realisation. Now, I'm absolutely sure that's correct in some cases of these kinds, but I don't think that's the case here. I don't think it's the case, and indeed it wasn't the case in how the case was presented, that Madame Lily's difficulties with her mental disorder were being so impacted by the abuse from her mother that she was rendered lacking mental capacity to decide. I also do generally think that capacity can be something of a red herring in safeguarding practice, relevant but often not determinative in thinking about the kinds of problems or solutions we might have in responding to these hard cases. The second line of argument looks at what we might call undue influence-based justifications. So the idea here might be something like this. When a person is refusing help, we shouldn't respect that refusal if it's the result of coercive pressure or undue influence from the abuser or somebody else. That invalidates the withholding of consent for help, and therefore you can intervene to safeguard the person by protecting them from the undue influence or the coercive behaviours. Now, that's the approach taken in England. In the common law, the exercise of the inherent jurisdiction of the High Court says, yes, we can intervene to protect adults with capacity in these kinds of situations. But I am not totally convinced that the undue influence line of reasoning is going to get us very far. It is very unclear to me precisely how the influence of one person on the decisions of another person, after all, that influence is a feature of all of our lives, all of the time, within our relationships, can directly and explicitly undermine the consents that we give for refusals of these kinds. That is to say, when does mere influence, that is to say, the decisions that we make being influenced by others, we change our plan, we change what matters, we change our value commitments, we decide otherwise, when does that everyday influence become undue influence? And can we articulate that in the consenting process without falling into problematic reasoning that conflates undue influence with the avoiding of an outcome we want to prevent, namely a bad decision being made? I would propose, and this is a controversial view, that even in a direct threat scenario, if the woman's mother was behind the door threatening her to say no, that woman could still resist and make a judgment in line with her considered view, potentially. So I don't think undue influence is going to get us where we want to get to in cases like this, but I want to put it out there because I imagine many of you will disagree with that view. Here's a view that I'm more inclined to think has weight in this kind of discussion. We might justify overturning a refusal of help in a case like the one I described when thinking about the ways in which living in an abusive relationship can impact directly on a person's life plan and the exercise of their agential control. One thing we might think about with certain abusive behaviours is they can strip people very basically of the fundamental ability to pursue a life they have reason to value. And if we accept the shift from a sort of thin autonomy-based account of decision-making towards a richer agent-focused account of capabilities, thinking about supporting agency of their ethical obligation, we might think this is a place in which that refined duty can do us some work. What I'm imagining here is a situation where the constraints placed on a person's life can deprive that person of the substantive freedoms they need to realise their capabilities now and into the future. And I've tried to offer a partial defence of this kind of justification for overriding refusals of help in this context. And I want to just present another kind of case scenario, a very odd one in a way, but one I think can be usefully help to differentiate situations where this argument might do some work versus where it might not. We have Maggie, a young woman who decides to join a religious cult, and she relocates to live with the cult members on a remote farm in the countryside. She cuts off all contact with her family. She shares her money with the other members of the cult. She works on the farm, and she conducts all her social activities within the farm environment. After 12 months with the cult, she happily signs a new code of conduct instigated by the cult leader. This code involves the leader of the cult locking all members into their farm cottages at night and indicates that any members of the cult who attempt to leave the farm will be prevented from doing so and will be punished for violating the code. Now, in one way of understanding this kind of scenario, we might say that Maggie's agency was not compromised to the extent to which we have to worry before she signed the code of conduct. At the point at which she signed that code of conduct, the constraints placed upon her freedoms, her capacity to pursue a life of value, was so much more significant that we could say, on agency-based grounds, and the supporting of agency-based grounds, that we would invalidate her signing of that code of conduct, and we should intervene to protect her from the nefarious influence of that cult. And that distinction is drawn by the severity and the impact of those constraints. Okay, two final justifications just to review quickly. This is an important one. Harm to self justifications. We might simply think that in cases of the kind I presented, we can override a person's refusal of help because we want to protect them from harm. And that is indeed the justification codified in the VAA, when in part at least it says that these orders can be given when it's necessary for the protection and safety of the vulnerable adult. This is a kind of pure paternalism with procedural protections approach. The VAA allows paternalistic interventions of those kinds for the benefit of the person in protecting them from harm, but only when the person's views, wishes, feelings, values, and beliefs have been considered, and the invasive measure is the least restrictive alternative on the table that's viable. Importantly, it excludes administering medical treatments from the scope of orders that can be issued. It can be only used for restricting contact and removing the person from the home. For medical treatments, that could only be done with consent or in the best interest if the person lacks capacity. Now, this paternalistic rationale in the VA looks immediately problematic, we might think, I hope. It's not a justification that we typically accept in clinical ethics or in other clinical contexts. We typically allow people to put themselves at considerable risk of harm or death, i.e., to make unwise decisions by refusing medical treatments if they have the capacity to do so. Why would or should things be different for this decision in the home context? And why limit it only to removals from homes and restrictions on contact? Surely they are as significant in a person's life than a medical intervention might well be, and potentially as troubling, problematic, or worrying than they might be otherwise. Why carve that out in that way? So I'm unconvinced that we have that clear paternalistic justification in place. And the final consideration, which is, I think, one we might not typically use in the clinical ethics context, is what we might call a perfectionist or social value type justification. That we should intervene to stop people consenting to continue to be abused by recourse to what a decent, harmonious, caring society buys into. Something like this. We're not the kind of society that should accept abuse within caregiving relationships at any cost, even if that means not respecting consents. And so consenting to continue to be abused or to be placed at heightened risk of abuse undermines the very fabric of our commitments as a society, threatening its core values, and should not be respected. I'm reminded in thinking about this of a very famous English case in the House of Lords, Lord Templeton's words in preventing people from consensually taking part in some very harmful sadomasochistic sexual activity. And he says the following: society is entitled and bound to protect itself against a cult of violence. Pleasure derived from the infliction of pain is an evil thing. Cruelty is uncivilized. And that kind of reasoning, I guess, may come into our justifications outside of the relationship, outside of the person's own value commitments, outside of doing good for that person, by reference to what the society should care about. And as a matter of public policy, therefore, we shouldn't respect those kinds of refusals in the case I presented. Thank you very much. I hope that was interesting and a good setup for our panel discussion to come. As always, please get in touch if you'd like to follow anything particular up in my talk.